Good morning. We are going to discuss uh, the disease and condition of diabetes and the documentation opportunities that we can use to ensure that we're capturing all of the conditions that are being evaluated, treated, worked up for, and that are linked to diabetes. So again, that we can capture the appropriate codes to the highest specificity. Once again is the disclaimer statement. Every effort has been taken by the author of this presentation to ensure that the information shared was accurate and current as possible at the time it was developed and presented. The primary intent of this presentation is to be informational only and to share this information in a manner that is more relatable and understandable to those in healthcare with various backgrounds and levels of experience. The information that is shared is only intended and not to take precedence over any state, local, and/or federal guidelines, organizational policies, and/or procedures. So these are some of the documentation um, of diabetes that are important so that we can capture all the appropriate codes. Again, this does not change the care that you deliver to the patient. The patient will still receive the same excellent quality of care. However, the increased specificity that you are documenting within the patient note does lead to better continuity of care clinically. So there's a better continuity of care with the increased specificity of documenting any conditions that the patient is being treated for and being specific about these elements in regards to diabetes that I'm going to mention. So if they have diabetes, document the type. It includes the causal the cause of it, the etiology. If no type of diabetes identified, then it's coded by default to diabetes 2, or you may be receiving a clarifying query from the coder if they notice like it's documented by a consulting provider as a certain type of diabetes with the cause, and it's not reflected in the attending provider's documentation. So just be aware of that. If it's controlled or uncontrolled diabetes, further document if the uncontrolled diabetes is hyperglycemia or hypoglycemia. Link in the documentation to any other related conditions, cause, or again related to the diabetes. And when you say that, when you link documentation, say that it is due to, so for instance, neuropathy due to diabetes type 1 uncontrolled. So please document with specificity. So when you're linking the documentation that is due to the diabetes, such as neuropathy, nephropathy, retinopathy, peripheral vascular arterial disease, congestive heart failure, foot ulcers, gastroparesis, document clearly and concisely as to the type of diabetes instead of using such terms as brittle diabetic, labile diabetic, idiopathic diabetes, or juvenile onset. When you document clearly instead of using these terms, it will prevent a clarifying query from the coder. So again, let's just get ahead of the game. It will save you time if we can document with specificity the type of diabetes, if it's controlled or uncontrolled, and link it saying that, the nephropathy is due to diabetes type 1 or whatever. But please be clear and concise. So there are other documentation opportunities related to diabetes, such as hyperglycemia that would be due to failure of the insulin pump. Make sure that you document that if they have an insulin pump that is not working effectively that led to the hyperglycemia. Identify CKD and specify the stage. So if the specificity of the stage is noticed in the notes by the nephrologist, but it's not reflected in the attending provider's notes, again, you will be receiving a clarifying query. Any type of heart disease, such as coronary heart disease, that is due to the diabetes needs to be documented. If they have CHF due to the diabetes, then that needs to be documented and the stage of the CHF. Diabetic heart disease, such as diabetic cardiomyopathy, heart failure, specify the stage, coronary heart disease, coronary artery disease. All other ophthalmic conditions, such as retinopathy, cataracts, and or glaucoma. Diabetic ketoacidosis, another condition rarely heard of, but it's very serious complication of peripheral neuropathy, is Charcot-Foot. So if they've got a stroke that's due to diabetes, a myocardial infarction, MI, always document the actual BMI, please. That is a very important aspect of this. So once again, let me please emphasize the necessity of the provider needing to document the presence of a cause and effect relationship link for the condition listed, or if there's not a causal relationship between the diabetes and the listed conditions. Why? Because this is if there is a link, it affects the code assignment to its patient count, or if there's not a link, it affects the condition assigned, the code assigned to the patient account. And it will save you, like I said, from a clarifying query. I understand the workflow and the demands that we are all under to care for the patients that we have. And queries are just one more thing that we have to stop our work for and then look into the old patient count. Because when we have coding assigning the queries, sending out the queries, it's usually after the patient's already been in the hospital. Their hard chart and electronic chart are sent to health information management and coding team to assign codes to every single diagnosis and every single procedure. And then as they're working up the primary and secondary major complicating conditions or comorbid conditions, or just a non-major complicated comorbid condition, they are going to send you clarifying queries at that point. So after the patient's already been discharged, their chart, electronic and hard copy, because we use the blended records in some institutions, and it goes to the coding team. So that's 2 weeks that it takes to assign codes after a patient's been discharged. So that's when you're getting the queries. So let's just kind of get ahead of game, and so you're getting less of these queries, and it will really help your workflow and also be more accurate, right? Because everything's always more fresh in our minds and in our thought process at the time that we are caring for the patient. If you have to be fortunate enough to work in a hospital that has a clinical documentation integrity specialist, these clarifying queries are done concurrently during the admission, usually starting about 24 hours after the inpatient admission, so that the CDI professional is able to look at the chart and really see what the provider is thinking. Nobody can read the provider mind, so whatever you're thinking as far as like being the cause of why you have to admit this patient, uh, needs to be documented in the chart to help support the medical necessity needed for the inpatient status of a patient in an acute care hospital. So once again, um, it is important and critical to document the provider thought process in terms of monitoring and the treatment plan. It will help to justify medical necessity of keeping a patient in inpatient status in acute care bed. If there is no medical necessity to justify that inpatient status in an acute care bed, then we will get denied payment. We are delivering all this care for free. Um, Lastly, document as to if the DKA, diabetic ketoacidosis, or mild diabetic ketoacidosis, was or was not present on admission. POA, present on admission, is another term you will hear commonly. And once again, this all leads to the bottom line. No money, no mission. And if we want a place to carry out the mission, then we all need to work as a collaborative team to keep the hospital doors open. Again, I use several resources as I work to develop these videos. A lot of them are different revenue cycle coding, uh, different resources that I use that I want to share with you all. And again, my journey in revenue cycle and coding really is due to the fact that I know how hard all of us work at the bedside and the resources that are used to take care of these patients. And I know that we need to justify the dollars spent in order to capture and cover our operating budget, and in addition, turn a profit so that we can also provide more services, more physical therapy, more um, interventional radiology, develop a cath lab, an EP lab, all these things that really will serve the patients we care for. Next, I'm going to show you the next page of slides of references that I use. Again, this is just another set of slides, different coding organizations. I use CMS themselves and a lot of other different resources I'm just sharing with you here. Lastly, I really want to thank you from the bottom of my heart for all of us participating in this conversation and these learning lessons about hospital revenue cycle and how our documentation is so critical and elemental to the appropriate signing of codes to the highest specificity so we get a proper working diagnosis that really drives the assignment to the diagnosis related grouping that has a unique relative weight assigned to it, and that unique relative weight reflects the amount of resources that are used to take care of that group of patients. So it reflects the intensity of resources, and then also ultimately affects the hospital payment. Again, simple calculation. It is the relative weight times the hospital-based payment rate that equals the reimbursement for that patient for that DRG. Again, the hospital-based payment rate is unique to each facility, and it's based on geography, labor relations cost, non-labor relations cost, wages for the area. So again, we all need to work together because my goal is to provide and share and encourage the exchange of information that exists across many silos in healthcare settings. My belief as a healthcare professional is that we all are on one team that shares the common goal of providing care to patients in need. Thank you. Have a great day. And again, thank you for participating.